Hi, good evening, everyone. Welcome to the class 4 of clinical cardio class. And this is for the programs for the 3C of young cardiologist. And today we have case presentation by Dr. Maulik. He's going to present a case of tetralogy. And we'll have our faculty expert joining, Professor Aditya Kapoor from SGPGI Lucknow. He'll be taking us through an approach for the case of a decreased pulmonary blood flow in a patient with the ventricular septal defect. So his approach is going to cover what is called as physiology and how to approach a case. So before that, myself and Dr. Majan sir, good evening and welcome to the to being the co-host along co-organizer along with me, Dr. Majan sir.
Good evening. Actually, this is one of the most important topics for all the PG students. So, decreased pulmonary blood flow physiology. Today there is a lot of learning opportunities for each one of us, including me. So, I don't want to come in between. Just I want to all the best for Dr. Mayank, and we'll start presentation.
Thank you, sir.
So, welcome, Dr. Maulik. Over to you, and we can start with your case presentation.
Good evening, everyone, and respected teachers. Thank you for the opportunity. So today, I am presenting the case of 2-year-old male Arushi Parwar, firstborn our child out of non-consanguineous marriage, coming from low socioeconomic class, residing at Amreli, and history narrated by her mother, which is reliable. Presented with multiple episodes of fast breathing episodes associated with bluish discoloration of lips, tongues, toes, and fingers, which just noticed from the age of 1 year, and history of fever since 15 days.
So, Maulik, when you mentioned this history,
Yes.
a couple of questions that can be asked is why is the history of non-consanguineous marriage important?
Because in consanguineous marriages, genetic syndromes are more likely, like sensory neural defects, and then also some VSD and PDA like disorders, and genetic syndromes are more likely to be.
So, from cardiology perspective, which are the disorders that run in consanguineous families? Okay, what type of genetic disorders do you expect to be more prominent? Autosomal dominant, autosomal recessive,
Autosomal
X-linked,
recessive, sir.
mitochondrial?
Recessive, sir.
Recessive. What about the zygotic series? Have you read of dizygotic versus monozygotic series in tetralogy?
No, sir.
So you should know dizygotic versus monozygotic twin series.
Yes.
It's given in Moss Adams as well. It's given in the book as well that it's like dizygotic versus monozygotic twins. What is the hazards or likelihood of tetralogy being more common? Also, that also goes on to establish which are the genetic linkages with tetralogy that you know of, which means which genes, which biochemical receptors, which are the mutant pathways, what are the regulators of tetralogy, and which gene codes are is associated with the tetralogy. Have you read that?
Sir, genetics, there are TBX5 mutation and NKX 2.1 mutations are there. Other than that, there are some syndromics like 22q11 deletion or micro mutations leading to Digeorge or any other syndromes, plus other trisomies with Down syndromes and other trisomies can also.
So, what is catch 22? What do you mean by catch 22?
Sir, there is a hypocalcemia, conotruncal anomalies, cleft palate, then thymic hypoplasia, and abnormal facies, sir.
Very good. What do you mean by 22? Why 22?
Sir, chromosome 22, sir, on long arm of chromosome 22, 11th segment.
Correct. So 2211, that's the reason. 22q11, that's why it's called catch as an acronym for the manifestation. Okay, conotruncal anom. So consanguineous marriages, is it specific to any religion?
Mostly in, sir, Muslims and mostly, sir, in Muslims.
No, so it's not even down south. There are various sub caste system where the consanguineous marriages still exist. So, can you give me an example of what you mean by Mendelian heterogeneity, how it has impacted occurrence of risk factor. So Mendelian heterogeneity means that more crossbreed. Suppose a Caucasian marries a Chinese,
Yes, sir.
or an Indian marries a European, or an African black marries, say, Australian Aborigine. So this is going to create more uniformity to arrive at. And when this kind of crossing is there, is it more likely or less likely to cause associated genetic disorders or cardiovascular disorder?
Right, that I haven't undergone, but sir, most like less likely that will be
Less
associated.
likely, because
Yes,
that's what is called as epigenetics. Improvement in genetics, when you cross over between two variants, it's the better outcomes that come between the crossing over. And so genetic heterogeneity yields better genetic profile of the cohort. Okay, the best example is lipid profile. So if you look at dyslipidemia prevalence in certain communities, and when there is crossing over, you can see that it decreases. All right. Can you now tell me about the bluish discoloration at 1 year? So what are the causes? What are the disorders that are associated with cyanosis at 1 year, or onset of cyanosis at 1 year?
sir, it can be cyanosis because of a decreasing pulmonary blood flow, because of a tetralogy or any other means top like physiology, uh, in which means if TGA or DURB is there, will not be much severe because if it was severe, it will be presented early. Second is can be Eisenmenger also because of Down syndrome, ABCD or epipinto that can starting Eisenmengerization at 1 years also, or truncus. So it can be Eisenmenger or either mostly because of a top physiology, sir.
Okay, so tell me causes of cyanosis at birth. Commonly asked question.
So cyanosis at the birth is sir either means because of tricuspid atresia or tetralogy of Fallot, then means with critical top or either TGA.
Tetralogy failure causes cyanosis at birth. Usually, is it common?
Usually
You
not
should not
common,
utter
sir.
the word of tetralogy of fellows at birth. You should utter first should be transposition physiologies rather
Transpositions.
than
Yes,
tetralogy. So transposition should come as a first. Five
yes,
T, five T's and two ATs.
sir.
So
5T, 2P, 2 single. That's how you remember. Two
Yes, sir.
single
Might be
atrium.
sir tricuspid atresia and pulmonary atresia. Then sir left hypoplastic left heart, critical aortic stenosis or interrupted aortic arch, where the drug dependent circulation is there, so that patient will have from birth either shock or cyanosis, depending on.
No, no, you should stick. See, what that Margin sir is saying is that you should, when you are asked cyanosis at birth,
Yes, sir.
don't speak tetralogy as first. So it is
Yes, sir.
tricuspid atresia, TAPVC,
Yes,
truncus,
yes,
that is at the
truncus.
T, T, and T.
Yes,
Okay.
sir.
Then comes everything else. And then two single atrium, single ventricle.
Ventricle.
Yeah. And two P's. What are the two P's?
So persistent truncus arteriosus.
Okay. So, and fever, 15 days fever, how
Sir,
does that bring out?
primary
What does,
pulmonary hypertension, sir. It can be.
yes, correct. P is PPHN, primary
Okay.
pulmonary hypertension of neonate.
Mm.
Correct. So, why is the history of 15 days important of fever, or what are the disorders that bring out worsening or pathophysiology of fever worsening a patient's cyanosis or bringing out a cyanosis?
Uh, Sir, in fever, there will be hyperdynamic circulation and systemic vasodilatation. So the
Or etiology of fever, what kind of fever will actually worsen your cardiovascular disorder?
can be infective endocarditis,
Yeah,
sir.
very good, very good. So, infective endocarditis, where is the vegetation usually present in tetralogy?
Sir, in pulmonary valve means MPA or means in pulmonary arteries.
Right, so in pulmonary vein, towards the RV side or towards the PA side, usually
Towards the
of the
PA side.
towards the PA side. Correct, good. Why? Why is it so?
Because there will be jet hitting at that, and because of their turbulence
What
will
are they called as?
sir,
The
Venturi
jet
effect.
is called as?
Venturi effect, sir.
No, 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 no. Jet is called as eddy currents.
Eddy
These are
current.
eddy currents. Eddy currents will, so the three mechanisms of Virchow's triad of development of, so sink, pressure difference, turbulence, stasis,
Yes, yes.
So that's where that will happen. So sometimes you may be asked which are the disorders, where do you get vegetation in a patient with infective endocarditis? So eddy currents deposits are primarily on the pulmonary surface of the pulmonary valve on the PA side. That's why there's most of the vegetation that's on the side that you're looking at. Yeah, so cyanosis at birth, you said. So what is the classical time or of age when cyanosis starts appearing in a patient of tetralogy?
Sir, between 3 to 6 months, sir, classically.
4 to 6 weeks is what the classical answer is, but you
Yes,
can say anytime between 6 weeks to 6 months.
6
It can
months.
vary, but 3 months is also acceptable in certain books like Perloff. It is mentioned 4 to 6 weeks. Moss Adams says 3 months. So anything in why is it so? That's another common question. Why does that
Because
cyanosis?
will be increasing activity of the child, and the
One,
second is PDA will start to closer, so
the PDA
will
closes.
decrease the, and infundibular spasm will worsen, sir, with
No,
age.
something more which disappears.
What is about
Fetal
fetal
hemoglobin will start disappearing. Fetal hemoglobin.
So why fetal hemoglobin disappearance will bring out cyanosis?
Because fetal hemoglobin has a higher affinity for the oxygens compared to adult hemoglobin. So
Affinity is more or deliverability is more?
deliverability is less, sir.
No, sir, if deliverability is less, then more fetal hemoglobin means less oxygen through the tissue. So cyanosis should be more.
But
It
sir,
binds more and delivers
oxygen
more.
will stay in sir capillaries rather than extracted by tissues. So it will not sinus will not be that much evident, sir.
So you mean to say all children are cyanosed in utero?
No,
They
sir.
have 100% fetal hemoglobin.
No, sir.
Anything, any other reason why cyanosis worsens? So you said activity, you said fetal hemoglobin, ductal closure, infundibular spasm. All right. Then what is the what are the causes of cyanosis apart from tetralogy, or what are the mimics, or what is the differential of a cyanosis appearing in a child at 3 months, or say 4 to 6 weeks when the classically tetralogy cyanosis appears? So what differentials come to your mind?
Can be the respiratory disorders also.
No. When so in a cardiology exam, Maulik, when you know, you
Yes.
should not say respiratory. You know so much of cardiology. Why you want to say respiratory?
Yes.
So whatever differential you are going to speak on, your final differential is the differential of cyanosis as well. That's
Yes,
why
sir.
it's a differential. What?
Sir, can be sir transposition physiology, sir, TGA, or
No, transposition is cyanosis at birth. We just discussed. You
yes, sir.
cannot have TGA without cyanosis at birth. Very rare,
Yes, sir.
unusual.
Uh, VSD, sir, PS physiology, sir.
Yeah,
Anything?
VSDPS. So you have DTGA, DORV,
Yes,
VSDPS, DTGA,
PS.
VSDPS. Anything that's got VSDPS, decreased pulmonary blood flow. This physiology, all of them can present later on. Right. What about abstinence? Severe abstinence
Severe abstinence, sir,
with
initially
ASD?
with ASD, initially there will be right to left shunt, so patient will be sinus, but later on with RV and RA compliance increases, so shunt might go decrease and cyanosis disappears, and when further RV failure occurs, then patient will get again cyanosis. So there can be sir vaccine waning types episodes. Abstinence can be there.
So it's called as bimodal peak.
High modules, yes.
Yeah, bimodal peak. First peak in childhood, second peak in usually what age? Which decade?
Fourth or fifth decade, sir.
Correct. Good. Fourth to fifth decade. Very good. All right. So I think we've covered most. Majan sir, any other question or shall we move again?
In patient with the severe pulmonary stenosis with RV dysfunction, sometimes you may get cyanosis. That is one of the cause. So pilot triology, it is one of the cause with the associated small ASD or stage PFO.
Yes, sir.
That is late onset cyanosis. Yes, you can move forward.
Yeah. So and tetralogy not presenting with cyanosis within first or life year. What would be the cause? Patient has tetralogy, but he doesn't present with cyanosis.
Sir, patient is having a good pulmonary blood flow because of pulmonary stenosis is not that much severe or either
Very
having
good.
large PDA or large MAPCA, sir.
Very good. Very good. So go ahead. Next.
So as per her mother, child was apparently fine during first 10 to 12 months of the age. Then she noticed that she has episodic fluid discoloration of lips, tongue, toes, and fingers since age of 10 to 12 months. These episodes were more common when waking up from the sleep, crying or feeding, which was associated with fast breathing and lasting for 3 to 5 minutes. It was not associated with the loss of consciousness or seizure, but the child was more sleepy and floppy after these episodes. So she visited a nearby physician and was diagnosed with some heart disease and advised a surgery, but they didn't undergo surgery at that time. So.
Okay.
Uh,
So, sorry, sir. So, Majan sir, you were saying something.
I was not seeing. You can continue.
Yeah. So, Maulik, which surgeries are ideally done at which age? ASD, VSD, tetralogy, PDA, DTGA, CTGA, CCTGA, tricuspid atresia, Epstein's anomaly, pulmonary atresia, pulmonary TOF with absent pulmonary valve. You should know at what age ideally they should get operated upon. So ideal age for operation. Let's stick only to tetralogy today. Other questions. These
for
are the questions.
tetralogy, sir, ideal age is from 3 to 6 months as per the sir, literature and Western world data. But in India, sir, around 9 to 12 months, most of the patient get operated
Very good. So it should be ideally be within first year of life.
first year of life.
Yes. So first year of life, and I preferably at 3 to 6 months. So you are correct. So that's correct. 3 to 6 months. And what should it be? Single sitting, or you can do a BT shunt first and then do a
Sir,
tetralogy?
it depends on
One
the
stage or two stage?
Sir, depends on
Good
pulmonary
anatomy.
anatomy, sir. If pulmonaries are adequate size and there is no coronary abnormalities, we can go with a single stage and it is actually better. But if patient
Correct.
has this kind of anomalies, then we have
Which
to go
okay, so that's correct. So single stage is better than
single
two
stage.
stage. Next
Yes.
question. Which approach? Atrial approach, ventricular approach?
Sir, whenever feasible, atrial approach is better because it
Atrial approach. So Dital
doesn't
series showed that atrial approach is better. Lesser scar, lesser widening of QRS, lesser PR, and of course no arrhythmia and longevity is improved. So that's from the Dital series. Okay. Then one stage, one age, which approach? I think we've discussed all. So ideally, that's when it should be done. Good. Okay. Which is the largest series of tetralogy of adults published, oldest one in India?
Sir, from sir CMC, well, or I think, sir, there is a series.
Yes, Charian series. I think that's, if I'm correct, 100 plus first series published about 100 plus adult tetralogy operated and their outcomes. Published probably in Lancet. So that's from Vellore, correct.
The child was apparently fine between such episodes. These episodes were frequent initially, but later on it decreased. And last such episode was before 11 months. After that, patient doesn't have this kind of episodes. So now the patient has the complaint of fever with chills, high grade, on and off since 2 weeks, which is not associated with cough, cold, breathlessness, abdominal pain, urinary frequency, joint pain, skin lesions, and for which they have taken injectable treatment from the outside physician and since last 7 days, and now fever is relieved, sir.
So causes of fever in tetralogy. So one already we discussed, maybe a potent infective endocarditis. What else can be worrisome? And these are the site of infection that you should closely be watching out for.
So the
In a
second is a
patient with
patient
tetralogy.
can have AR because of tetralogy, and that can also develop.
Fever. I'm asking fever. A patient of fever in a patient of
So
tetralogy.
there can be the
Etiology is to
brain
rule out.
abscess can be there.
Very good. Brain abscess. Then
And so tuberculosis can also be there.
very good. Tuberculosis is more common as compared to patients with a normal
And
heart.
so there can be septic emboli and pulmonary infarcts, which can lead to
Pulmonary
secondary
infarcts. Very good.
aorta.
Then
And
can acute gout cause fever?
yes, sir, but sir, this age patient will
This
not.
is unusual. I'm just asking in general. So these patients can also have hyperuricemia and gout, and acute tophi and pain, fever can also be sometimes be there. So those are the things. And hyperviscosity, can it lead to something else? So again, the question can be modified. Causes of altered sensorium and tetralogy.
Right, because of sir, either brain abscess, then
Okay.
central venous sinus thrombosis.
Venous sinus
Venous
thrombosis.
sinus.
Very good.
Then it can be, means because of hyperviscosity, there can be headache, giddiness, and blurring,
Correct.
that kind of symptoms.
So hyperviscosity syndromes. Very good. Okay.
No history of altered sensorium, loss of consciousness, seizure, limb weakness, headache, giddiness, decreased vision. No history of recurrent respiratory tract infection. No history of feeding difficulty, refusal of feed, success cycle, or forehead sweating.
Why
No.
is it important? How do you ask for it? Suck cycle.
So the patient's mother will tell that the patient initially the child takes feed for some time, then it stops feeding, and then again starts feeding, and at the time
How
patient.
so? How long is this duration? Seconds, minutes,
Sir,
1
minutes.
minute, half minute, 2 minutes, 15 seconds, 10 seconds.
Sir, minutes.
No, if the minutes, he'll finish the feed. It's for 10, 15 seconds the child sucks and then rests. So it's not even in minutes. The child is ever hungry and it's in seconds, half a minute, 15 seconds, 30 seconds. It cannot suck more than that because he's too fatigued and tired. Right. And he's always hungry because he's in a hypermetabolic state. Can you guess what amount of energy do they end up spending in breathing, these children, if they are in failure? 5%, 10% of their metabolic energy requirements.
Around
20%.
30%.
60% of their energy is just lost in breathing. That's how depleted they may be. Okay. So suck represents a hypercatabolic state and tired child with heart failure, forehead sweating, as you mentioned, and refusal to feed. Okay.
No chest pain,
So
palpitations.
chest pain, palpitation, child is not going to give.
Yes. Means
So crying,
palpitation is
you can
around
just have
3 year
excessive
age,
crying.
so that can sir give history.
How? No. So this child cannot give history of chest pain and palpitation.
Yes.
So increased precordial activity. Mother does not report this fine. Precordial activity. That's all so that you've already mentioned as a separate point.
Yes.
Right. So no chest pain palpitation will come here.
Yes.
And remember not to make this kind of mistake when you're taking a pediatric case. Yeah.
No history of dependent edema, abdominal distension, or decreased urine output. Perinatal history. Patient is having a full-term normal vaginal delivery. She was cried immediately after birth, and birth weight was around 2.5 kg. No history in perinatal period of bluish discoloration, jaundice, NICU stay, or other major complications. Patients were exclusively breastfed for 6 months and then started on supplementary foods. And she has been vaccinated according to mother till age. And there is also no history of contact to any TB case in perinatal periods.
What vaccine do you avoid or are be cautious with in a child with CNS complications in tetralogy or nowadays you don't need the previous versions of it used to be which component of MMR?
Uh, Measles, sir. I think.
Correct. But now previously we know it was what component. So now they don't use that so that lysyl lineage. So now it's no more a contraindication, but just somebody who's an old timer aware of the same complication. That CNS complication in a tetralogy and a vaccine that you're talking about. So Viva, just if you want, they want to go away from what's the classical Viva. These are some of the questions that you may be asked or tracked upon. Okay.
Maternal history. No history of hypertension, diabetes, or thyroid disorder in mother. No history of smoking or alcohol during pregnancy. No history of any other drug intake during pregnancy, and no fever with skin rash or other infection during pregnancy.
Developmental delay, you said. So do you expect them to be normal? Are classically developments normal in tetralogy or slightly delayed?
Classically, sir, there can be somewhat physical underdevelopment, but mental development is normal if a patient does not have recurrent spells. If patient is having recurrent spells and with recurrent hypoxia, mental
Yes.
also can be, sir.
Can be slow, can be slow.
Mm.
So physical milestones, 6 sitting, 9 standing, 1 year walking are the 3 classical milestones that you can easily ask and remember.
Yes.
So 6, 9, and 12, and 18 independent walking, and then
Yes.
words and syllabus. So you should know a couple of milestones for 3 months each,
Yes.
just in case a pediatric specialist. Now we have pediatricians who become pediatric fellow FNB. and they are DNB examiners. Just in case for those DNB students who are appearing for a DNB exam, you can have an examiner who's DNB pediatric cardiology, and if he is your examiner, or usually they come in FNB, not in the DM cardiology or DNB cardiology, but sometimes you may be asked who's well aware about the milestones, just to know a couple of them. That would help you.
What? No family history of any heart disease among siblings or other family members, and no abortion or stillbirths. So as per the pedigree chart, patient is a firstborn female child, and second, he has also an elder son of 1 year, which is does not have any symptoms. Personal history: patient is a vegetarian and good appetite with normal bowel and bladder habits and with adequate sleeps.
Okay.
So summary, 2 year, 11-month-old female child, first born to non-consanguineous marriage, normal perinatal period, having multiple cyanotic spells noticed from first year of the age, which decreased by second year, without history of recurrent LRTI or CCF symptoms. So possibility this is a case of cyanotic congenital heart disease with a decreased pulmonary blood flow, and likely is a top physiology, and now having history of fever since 15 days.
All right. Dr. Aditya Kapoor sir has joined. Sir, welcome.
Hello.
Yes, sir. So this is the summary that we have. Dr. Maulik is doing well so far. He's discussed the common etiologies, presentation, clinical symptoms, manifestations, and viva voca of pathophysiological mechanisms, why cyanosis develops at what age and what are the differentials, and what are the things to suspect in a child with tetralogy who presents with fever. So he's just summarized the history. Sir, any questions or any comments? So you're muted.
Yeah, from my side, there are no questions.
Sir, Dr. Aditya Kapoor sir, you're muted.
सॉरी नहीं, मैंने कहा मैंने हिस्ट्री सुना नहीं था, तो आपने सुन लिया तो ठीक है. द समरी लुक्स प्रीटी कॉम्प्रिहेंसिव एंड दिस इज साइनोसिस व्हिच ऑनसेट कब हुआ था साइनोसिस का?
Sir, at the first year of the age, means between 10 to 12 months, and it was, sir, mostly spells, sir. Between spells, patient was, sir, doing okay.
डॉक्टर कमल सर, एग्जामिनेशन पे चलते हैं, फिर हिस्ट्री आप लोगों ने तो सुन लिया.
Sure, sure.
हिस्ट्री डिस्कस हो गया सर?
Yes, we have discussed this.
ओके, ठीक है. थैंक्स.
So general examination, the child is sitting comfortable, well oriented to time, place, and person. Mild central cyanosis is present. Grade 2 pan-digital clubbing is present. No pallor, icterus, edema, or lymphadenopathy. No facial dysmorphic features. No skeletal or hairline abnormalities, and no signs of no peripheral signs of distal runoff or infective endocarditis.
Why you are telling mild central cyanosis?
Sir, cyanosis is, sir, not that much, sir, apparent. So there is somewhat discoloration is there, sir, but it is not means classical cynos.
So is there any grading of cyanosis, mild, moderate, or severe?
No, sir, as such, no grading.
Okay. So if it is mild cyanosis, then what is the pink top?
Sir, a pink top, there is because of good pulmonary blood flow, sir. Because of there is large MEPCA or PDA or either less severe pulmonary stenosis.
So this patient is in that category only. Mild central cyanosis means pink top.
Sir, looks like that because patient does not have much developmental delay or any means other during between the spells, patient is also doing fine, and mother and doesn't say that she has noticed cyanosis during means without spells. So cyanosis appear mostly on spells only, sir, as per history, sir.
Is there any history suggestive of any taking a squatting equivalent posture by patient itself?
Sir, mother is, sir, not that means saying that patient is taking that posture.
No, but you can always ask, right?
Yes, means, sir, she not confident in saying that patient takes
Okay.
that posture. So
And does she
not include
mention
any-
what posture she likes to hold the child or the The posture the child adopts when she's holding the child on her arms.
She holds the child in the arm with her knees flexed, sir. Means
So
again.
that you should have mentioned, no? So you know
Yes,
that already, that if that is the case, it's a squatting equivalent. So then
yes, sir.
if she does mention that, that is.
देखो ये जो डॉक्टर कमल ने पॉइंट मेंशन किया बहुत इंपॉर्टेंट है कि आपको कई बार मदर से एक्टिवली हिस्ट्री पूछना पड़ेगा कि वो किस पोजीशन में पकड़ती है. शी विल होल्ड द चाइल्ड इन अ पोजीशन शी इज अकस्टम्ड कि द चाइल्ड विल बी कंफर्टेबल. सो दैट्स अ ग्रेट पॉइंट है ना.
Yes.
चलो.
So Dr. Vaibhav is asking a question to us, but I will ask that to you. Why brain abscess are more common among other foci of abscess in tetralogy? Why brain abscess?
Sir, because there is a right to left shunt, so the means the microorganism escapes the phagocytic function in the lungs, and secondary patient also have recurrent hypoxemia, which can lead to brain microinfarcts, and that will sedated by this organism and can lead to brain abscess.
Very good. Right to left shunt, which escapes pulmonary phagocytosis. Correct. That's correct.
Go ahead, sir.
Okay, you can move ahead.
Okay. Temperature is 98.4 Fahrenheit. Pulse is 102 per minute. Regular, normal force volume tension without radial or radiofemoral delay. All peripheral pulses are palpable and equal bilaterally. BP in all four rings is equal and around 80 by 50 millimeter of mercury. JP is not elevated and hepatojugular reflux is also absent. Respiratory rate is 30 per minute. Thoraco-abdominal. And saturation in right upper limb 88, left upper limb 89, right lower limb 89, and left lower limb 88%.
So that's the reason your cyanosis is not apparent. You need
Yes,
what
sir.
saturation to it become apparent?
Sir, around 85%, sir, it will.
Correct. So either you have or you don't have cyanosis, as sirs were asking you, except
Yes.
inky blue cyanosis, which is specific for one disorder described in Perloff. Other disorders, nobody. Which disorder they say it? Inky blue?
Don't know, sir.
Inky blue cyanosis. One is Eason-Manger, and second is an adult with an abstinence. If you have right to left shunt, only two disorders they describe it as inky blue. But again, I mean, I don't know how would that be different from anything else. Okay.
Here, the only one important thing is that the pulse rate is 102 because everything here is a dynamic thing.
Yes,
So
sir.
when there is a more tachycardia, the chances of more cyanosis, more desaturation,
Yes, sir.
more problem. If there is a less heart rate, then patient will be more comfortable, less cyanosis. So
Yes.
here heart rate is 102. So that is the one thing which is slightly worrisome.
Yes.
एक चीज बस क्विकली बता दो. द एग्जामिनर आस्क यू टॉप विद बाउंडिंग पल्सेस,
Yes, sir.
क्या होगा?
Sir, it can be because of AR or large
AR
MEPCA.
and excellent. AR and
MEPCA, sir, large MEPCA means
उनमें
collaterals.
कैसे डिफरेंशिएट करोगे? वन मोर पॉइंट अपार्ट
अगर
फ्रॉम
सर
अदर.
लार्ज मैप का होगा तो पेशेंट विल नॉट हैव दैट मच साइनोसिस, ओनली बाउंडिंग
ग्रेट यार,
पल्स.
वेरी गुड. मेरी तरफ से पास हो तुम.
Yes.
ग्रेट. सो बाउंडिंग पल्सेस AR एंड कोलैटरल साइनोसिस है तो AR फेवर में जाएगा. ठीक है. Okay.
Very good. So Maulik, again, because sir has asked this question to you, I've already discussed in a couple of previous question sessions as well. Commonly, you may be asked, tell me causes of raised JVP with tetralogy,
Correct.
cardiomegaly with tetralogy, tetralogy with failure, tetralogy with hyperdynamic apex, tetralogy with raised JVP. All the questions have common answer. What are they?
Because of sir LV
No, Hans, causes. What are the causes of tetralogy with cardiomegaly? What are the causes of tetralogy with raised JVP? What are the causes of tetralogy with hepatojugular positive? A different way of asking same question.
Yes, sir.
Tetralogy with cardiomegaly, tetralogy with heave, tetralogy with parasternal pulsation, tetralogy with palpable second heart sound. I can twist the question like anything, but the causes remain same. Answer to all these 5, 6, 7 questions is same. What are they?
Sir, there can be large means collaterals or PDA. Second is because of AR. Then can be sir LV dysfunction or RV dysfunction because of multiple ischemia, and then restrictive VSD sir can be there.
Correct.
Then
Infective endocarditis.
infective endocarditis.
Hypertension in adults.
Hypertension, yes.
Hyperviscosity.
Anemia.
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 AR.
Yeah.
You already mentioned. Correct. So those are the same things always fall into, these are the common questions that can be twisted around and asked you. They are asking one and the same thing.
What is the PS and pH paradox?
Sir?
What is PS-pH paradox?
Sir,
Pulmonary stenosis and pulmonary hypertension paradox.
Sir, it can be, sir, there when top with large PDA is there. So because of PDA, PVR will start rising, and patient is already having infundibulous valvular PS is there. So patient can have both PS with pH.
Any other condition where you have PS with pH?
And suppose something is absent,
Yes.
what happens in a top with absent pulmonary valve?
Absent pulmonary valve, there can be, sir, PS with means the PS and PH, sir, can be there.
Correct.
Mostly, sir, there will be presentation will be, sir, early before PVH.
Yes, it is a early presentation with a failure,
Failure
cardiomegaly.
and bronchial compression.
Yes. Okay, can you enumerate which out of all these top physiology, which is the top where you will get a very late presentation? First appearance of cyanosis at the age of 5 years or 6 years. Not a pink top, but top. What is a Ghazul?
Sir, Ghazul phenomenon, sir, there will be acquired, sir.
What is the natural history of non-restrictive VSD at birth?
Mostly, sir, non-restrictive VSD, means if the large VSD is there, then it will start Eisenmengerization, sir, by the age of, sir, 6 to 9 months, sir. And out of that, sir,
Earlier,
See,
3 to
one
6.
second, one second. You give the answer positively, and Eisenmenger should not come as the first thing. First is a large VSD is presenting as a failure, but the VSD might start restricting and become large VSD will become a moderate VSD.
Yes.
And patient will continue with a recurrent failure. Second
Yes.
is you might get a isolated right ventricular infundibular stenosis, and the symptoms of the VSD high flow will reduce, and that is good. And third is your Eisenmenger, that is a pulmonary vascular obliterative disease. And
Yes.
another important thing is that as far as the TOF is concerned, there are multiple level obstructions. One
Yes,
is infundibular, subinfundibular, then annular,
Valvular and
peripheral pulmonary stenosis,
yes, sir.
and what is the DCRV with the top physiology? The DCRV with the top physiology is the condition where you will get a very late presentation of the top. So the Ghazul and DCRV, these are the two things where you will get a late onset cyanosis as compared to other top. Okay, you can continue.
The anthropometric data, sir. Height is 86 centimeter, weight 11.9 kg with a BMI of 16.1. Upper upper arm circumference 13.1 centimeter, upper segment 44, lower segment 42, and arm span is 84. So CVS examination, sir. Inspection, trachea is in midline, precordium is normal shape with no bulge or pulsations in, apical impulse is not seen, no visible pulsations, scar, dilated veins or sinus, and no kyphoscoliosis. Palpation, tracheal position is confirmed. Apical impulse is in left fourth intercostal space, 1 centimeter lateral to mid-clavicular line, normal in character, diffuse with lateral retraction, RV type of apex. No peristernal heave or thrill, no palpable S2, no epigastric pulsation. Bilateral carotid is normal and equally palpable and no thrill.
Okay. So that's what I was asking. So go back. I mean, you may be asked thrills. So so peristernal heave in a tetralogy. What are the differentials? I already asked you. So
Yes, sir.
restrictive ESD. What is
Restrictive.
Hoffman variant?
Sir, restrictive VSD in top is of Hoffman variant.
So it presents early or late?
Sir?
It presents earlier or it presents late?
Sir, it presents, sir, earlier.
Why?
Because RV will have sir suprasystemic pressure and RV failure will be there, sir.
No,
Because
there's a restrictive ESD, no?
yes, sir.
So
It will be
tetralogy
sir
with
present
restrictive
with
ESD.
RV failure, sir, most likely.
So as sir was saying, you have multiple level obstruction. This will be
Yes.
another one more level added.
Okay, sir.
Okay, next.
Percussion lever dullness is in right fifth intercostal space, suggestive of situs solitus. Left heart border correspond to apex and right heart border correspond to right sternal line.
So what are the clinical examination findings apart from liver dullness that can help you in establishing the situs?
Sir, trabe's
Prob space, okay.
space. Yes,
But that will usually go with hepatic dullness. I mean, wherever you have the
yes,
other
sir.
side.
Up,
Or what else?
uh,
Which is the most specific way of establishing situs? Suppose you have all imaging modalities with you, and there is something which is ambiguous, and you don't know whether you're dealing with mesocardia, levocardia, dextro. How would you decide which is the most important
sir, appendage.
anatomical? Sorry,
Sir, atrial appendage is.
that's so that is for atrial appendages are for cardiac
Cardiac.
situs, right? Overall, I'm asking.
Overall, sir, bronchus, sir,
Very good, bronchus. So, what is that index called?
index.
Baldrige index, ratio of left main bronchus to right main bronchus, the length of the two, and more importantly, eparterial bronchus versus hyparterial bronchus at the hilum of the lung. So if you can image that with a CT or an MR, if you can pick up what is the relationship of the bronchus to the PA at the level of lung hilum, whether you have two. Because sometimes you may have three lobes versus two lobes, or two lobes by two lobes, two or two, three or three. That also cannot tell you whether the patient has got situs or not. But the relationship of bronchus with the main pulmonary artery in the hilum is the most specific thing to tell you which side is the situs when you're looking at overall situs. But in cardiac situs, yes, it's the atrial appendage is also not that significant because you can have that with isomerisms,
Yes, sir.
right? In isomerism, you may have duplication, absent, left side, right side, multiple things. Okay.
Auscultation. The S1 is the normal, S2 is single and loud, probably it is A2. No S3, S4, opening snap, click, rub or knock. There is grade 3 by 6, harsh ejection systolic murmur in left second intercostal space in left parasternal region, non-radiating and heard bass with diaphragm and during inspiration. No other murmur heard on precordium or back.
Okay. So more the murmur, good for patient, less the murmur, good for patient.
More the murmur is good because it shows very, it's prominent flow through stenotic pulmonary valves.
Right. So what happens to the murmur in a patient who gets into spell?
So in a spell, there is a pulmonic blood flow is decreased and right to left shunt is increased. So murmur will be lessen and they might be absent also, sir, during spell.
Right.
Suppose a patient's murmur has been changing of late in a patient of tetralogy that you've been seeing regularly. What are the different things that come to your mind? Suppose it's become compared to previously patient, the murmur has now become less audible. In a patient who has now become more symptomatic, apart from in an adult, there will not be further progression. So, what are the things that come to your mind as differential?
Sir, there is increase in sir right to left shunt is there.
So, what can cause it?
Sir, because
If
of
not
anemia.
increasing obstruction, if the obstruction is not increasing, what can alter the?
Sir, there can be sir anemia. There then fever means that can lead to peripheral vasodilatation.
Okay, so anemia, polycythemia.
Polycythemia, fever, and
Again, so it's the same way of asking different question. Patient can develop heart failure. Heart failure, the causes of heart failure.
AR, sir.
Just enumerate the same. Oh yeah, so development of AR, etc. Okay.
Other system, respiratory system, bilateral vesicular breath sound, no wheeze or crepitations, no ascites, no hepatosplenomegaly. Oral and dental hygiene is good. And there is a CNS examination is normal, no FND or ultrasensorial.
So classically, where do you auscultate for MAPKAs?
Sir, in the back, sir.
Back?
Sir, back between, sir, means between
Back and axilla both.
scapula and below the scapula, sir.
Right. So which are the commonest MAPKAs out of the three types that you find in an adult or slightly grown up child? What are the three types of MAPKAs?
Sir, there can be, sir, bronchial, then direct aortic, and then indirect from the branches of the
Which of them is the commonest?
Sir, direct is commonest.
Correct. Why it's important to know them?
Sir, because it may require, sir, coiling at the time of ICR.
If they are significant.
Yes, yes.
And if you're not coiling, what the surgeon will do?
It can, sir, unifocalize if patient
In patients with
pulmonary
classical talk?
atresia and
Atresia.
hypoplastic.
Okay.
So, sir, the diagnosis, the congenital cyanotic heart disease with decreased pulmonary blood flow, Fallot's physiology most likely top in sinus rhythm without CCF or neurological complications with possibility of infective endocarditis, with differentials in anatomy like classical top, otherwise DORV VHDPS, TGA VHDPS, or single ventricle with PS.
No, do you really need to put single ventricle here as a
TGA
differential?
सिंगल वेंट्रिकल TGA VSD PS डालोगे इसमें?
TGA VSDPS should be the cyanosis from birth. So
Yes,
if there
sir.
is cyanosis from birth, then only TGA VSDPS or tricuspid atresia. And the most important thing is that when you are uttering the word of TGA or tricuspid atresia, then your length of the murmur doesn't correlate with the cyanosis. You will get a loud
Yes, sir.
murmur and deep cyanosis.
Deep cyanosis.
Here you have to only keep the first only differential diagnosis is DORV.
DORV.
You can only talk on DORV. That's all.
Okay, sir.
Correct.
You cannot utter CCTJ also because your pulmonary artery, there is second space pulsations are not palpable. Then your heart size is slightly different. So
Yes.
so you cannot utter that only. It is only classical talk for DORV.
Okay, sir.
Is there any way that you can differentiate clinically DORV VSDPS and tetralogy VSDPS?
Sir,
Anything about murmur or thrill or something like that?
so DORA will have a thrill of VHD, sir.
So if you have a thrill of the pulmonary valve, what is it more likely to be? And which of the two murmur will not disappear in spell?
So DORA murmur will not disappear, sir.
Correct. And what happens to thrill? Which one is the?
VHD, sir, is associated with thrill, sir. DORV, sir, in DORV.
Also, the relationship of the great arteries, right? DORV, what is the relationship of aorta PA?
Aorta, sir, so mostly, sir, side by side.
Correct.
Yes,
And tetralogy?
tetralogy, sir, relationship is normal, sir.
No, you don't call it normal. It's called as dextroposed, which
Okay.
is slightly midway between the normal and left anterior. Right. So it's called as dextroposed, but yeah, I mean, most of the times it goes as normal. So it's not exactly side by side, but it's midway between what you expect DORV and normal. Sir, any other question?
No question from my side.
नहीं बिल्कुल सही है. So TGA का डिस्कशन हो गया, सिंगल वेंट्रिकल हो गया, ठीक है, looks good.
So can we have Maulik X-ray and ECG of the
Yes, sir.
patient?
This is the, sir, 12-lead ECG of well standardized ECG showing a normal sinus rhythm, and there is a right axis deviation, axis is around 120, and patient is having a right ventricular hypertrophy with a tall R wave in V1 with there is a early transition at the V2 and so likely sir classical top sir ECG is of likely sir classical top.
So how do you differentiate it from DCRV
Sir, the axis
or
will be
DORV?
more towards right towards sir. More than one means 130 or 140 more than. So it will more suggest toward the DORV, but it will not also not exclude the top, but more likely DORV.
Rapid transition?
Sir, transition, there will not be a transition, sir. There will be prominent R wave in V2 also in DORV.
No, what happens in tetralogy?
Tetralogy, sir, there is a transition at V2, sir. V2 will be, means R wave will be less in V2.
So rapid transition, that is what it
Rapid
is called. Why is it so?
Because V2 is sir looking at the means through the VHD it is looking at the so LV forces will be
So
counted,
there is no septum, right? So
no
no forces
septum,
at the
and
V2.
the infundibulum muscle is sir electrically not much active, so it will record like that, sir.
So no R waves of the septum.
No, sir.
If it is present, what do you suspect in a tetralogy?
Sir, restrictive VHD sir, can be.
Correct, Hoffman. Right. Okay. What's the ECG in a patient with other three features that you know of DORV?
Sir?
ECG features of DORV.
Sir, the more sir rightward axis deviation and there will not be a transition with a prominent means wave, R waves are there in rightward V1 to V3 sir, and
ये क्या बोल रहे हो तुम? Your more rightward axis is acceptable.
yes, sir.
What about the loop? DORV पूछा ना सर ने? Loop
Sir,
क्या
loop
होगा?
will be sir counter clockwise loop, sir.
One
That
is
is more
loop.
important.
Yes. In top sir there will be clockwise.
और ट्रांजिशन का उसमें कोई खास फर्क पड़ेगा नहीं बिकॉज DORV इज आल्सो VSD PS ना.
Okay, sir.
द मेन फीचर जो सर ने जैसे बताया काउंटर क्लॉकवाइज लूप एंड राइट एक्सिस डिविएशन बियॉन्ड 150 160.
Okay.
Dr.
आगे
Aditi is
बढ़िए.
asking causes of absent murmur in tetralogy.
Sir, because there can be sir pulmonary atresia. And second is during spells because of severe decreasing antegrade flow through pulmonary valve and
And
increasing right to left shunt.
okay, X-ray.
एक्सरे दिखाओ.
So this is a chest X-ray PA view. Well centralized, well exposed, showing there is RV type of hypertrophy with upward means apex. There is means indentation on the right side of the trachea, suggestive of right aortic arch, and there is a pulmonary bay is also concave, means there is means hypoplasia means of pulmonary. So this is suggestive of tetralogy of pellets.
So right aortic arch, how often it is present in tetralogy?
So around 5 to 20% cases, and if it associated with atresia, then it will be more than 25%.
Which disorder has commonest association with right-sided aortic arch? Commonest with?
ये तो बताना पड़ेगा.
Truncus.
Sorry, repeat.
Truncus.
क्या बता रहे हो?
Truncus, he said truncus. Truncus arteriosus. So do you think the vascular markings are okay or more or less or something abnormal? What's there in the lung bed?
Sir, the vascular marking is means good pulmonary vascularity is there compared to the top where we expect pulmonary oligambia. In this film, there is means good vascularity is there. That's why sir patient has not cyanosis at rest most likely.
So how do the the mapkas look like? I mean, if you were to look at, and can you pinpoint some mapkas here, or your pointer is working? I mean, as your arrow, can you
Yes, sir. Arrow
scroll?
is working. This map ka, sir.
Yeah, show me if you can mark where is some mapka on this image.
That can be, sir.
What do
This.
they look like? What do they
Yes.
look like? What is the name or the classical appearance given to a mapka? What do they look like? Okay, so you know of hilar comas. So X-ray can go in that direction. So you can be asked left hilar coma, right hilar coma, waterfall sign, left waterfall, right waterfall. You know those causes?
Sir, right waterfalls are in CCTGA, and
Okay,
then hilar coma in, sir, tricuspid atresia.
very good.
And
Left side,
left,
right waterfall. You said left.
left side, sir. Sir, sir, I don't remember, sir.
I'm sure Kapoor sir is going to take that across. So we've learned from sir's classes only. Okay, echo.
So this is, sir, situs solitus at so aorta at the right side and IVC is on the left side. Both SVC and IVCs are draining in the atrium, sir, left-sided atrium. This is a subcostal window showing there is a small PFO and with a bidirectional like shunt. Parasternal long axis view. There is a large conotruncal VHD with overriding of aorta, which is around 50%, with aortomitral continuity is present and with a good LV function.
So normally, what kind of conal tissue is present in your patient? Normally, is there any?
Normally, sir, there is a subpulmonic conus is present,
Okay.
and
What
in
happens in tetralogy?
pathology there is, sir, anterior deviation of that conus, which leads to RVOT stenosis plus overriding and VHD.
Okay, bilateral conus is seen in.
Bilateral, sir, in I think DOR,
Very
DOR,
good.
DOR.
Yes, subaortic conus is seen in.
Subaortic, sir, TGA,
TGA or CCTGA.
CCTGA.
And no conus is seen in.
No conus.
Okay, next.
Sir, parasternal short axis view showing a large subaortic VHD, and there is a pulmonic stenosis which is at infundibular plus valvular both level. Pulmonary wall is somewhat thickened. This is, sir, pulmonary arteries view. There is a vegetation is means hyperechoic structure is seen at the bifurcation of MPL and so LP and RPA. Can be, sir, thrombus or vegetation, but in view of, sir, fever, it likely to be vegetation is there.
And independently mobile, right? Its
Independent
movements are.
immobile.
Yeah.
Yes.
Okay.
Sir, normal biventricular function, sir.
So when you say independent, no, in normal function, you'll have to mention TAPSE. How much is the TAPSE?
Okay, sir. Sir, 5-chamber view showing aortic override and large subaortic VHD. And also there is RVH, a prominent RVH and RV enlargements. Pulmonic stenosis gradients are around 68 mmHg.
That's a peak gradient.
Yes, sir, peak gradient. This is a suprasternal view. There is a right aortic arch because the first branch is dividing into two, and there are some mapkas present. Turbulent is there. A subcostal view, sir. There is no mapkas from descending aorta.
What disorder does not happen with tetralogy?
Sir,
What?
coaptation or aortic stenosis
Why?
is less likely because a double stenotic lesion, then survival will be much.
Very good. So that's usually is fatal. Patient usually dies in utero. So
Yes.
that's why in life you don't see. Correct. Okay, so what would you like to do for this patient?
So the patient, as we started suspecting infective endocarditis, so blood cultures would be sent and started on the regimens and for at least 4 weeks because the patient does not have any emergency indication for surgery. So we can wait for 4 weeks of antibiotics. And then after, sir, we can go for corrective surgery because pulmonary arteries are good size. So, but sir, cath, sir, can we require because patient is having MAPCAS on echo. So either CT or cath to delineate if large MAPCAS are there that require coiling or can be left upon.
Also the coronary. Could you see the RCA?
Coronary, yes, sir, RCA or coronal branch or left crossing RVOT.
Okay. I think you did well. Good. I think one of the best presentations till the 4 sessions that we had. Dr.
Yes.
Majan, any question? Dr. Kapoor, sir?
नहीं बहुत अच्छा presentation है यार मतलब he handled the questions well and बड़े अच्छे flow में किया. Well done, Maulik. Well done.
Yes, sir.
Good.
So that was a beautiful case presentation on tetralogy. And I think with the shortcomings that we might have had, we would now like to invite Professor Dr. Aditya Kapoor, sir, for his presentation as to how to approach a case for decreased pulmonary blood flow in a patient with cyanotic congenital heart disease. So thank you very much, sir. Sir does not need any introduction. He is Professor of Cardiology at SGPGI Lucknow. And we all have been learning from him all across the platform and in person over all these years. So over to Dr. Kapoor, sir.
Sir, HOD, professor and head of the Department of Cardiology.
अरे sir. Am I audible, sir?
Yes, sir.
Yes, sir. Yes, sir.
ठीक है. So, in fact, we have Dr. Deep Chand here. So Deep is here with me. We are doing some arrhythmia workshop. So Deep is in Chennai and a very close friend. So सभी cases चल रहे थे. So I have taken the liberty of filing the cases onto Deep and so I'll start. So as Dr. Kamal and Dr. Ajay Mahajan was teaching us, is the pulmonary blood flow increase or reduce? सबसे पहले तो history wise यही देखना है आपको, ठीक है? So spells, spotting, and history of heart failure. Dr. Kamal pointed out a few scenarios when TOF can also have heart failure, so you should remember that. So spells and spotting अगर हैं, तो that is by and large pointer towards a reduced pulmonary blood flow. Then if you have history of heart failure, inability to thrive, long feeding times, profuse sweating after feeds, that is classical history of increased flow. Am I audible, Dr. Kamal?
Yes, sir. Perfectly. And we can see your screen as well.
Yes, perfect.
Thanks. Importantly, if initial symptoms of high flow followed by improvement, and paradoxically, the patient says, the patient's relatives or the parents say कि पहले सांस फूलती थी और feed नहीं ले पाता था और अब धीरे धीरे improve हो रहा है. So that is a sign of concern. Either it is, जैसा डॉक्टर अजय ने बताया था, slowly developing RVOT obstruction, which is gasolization, or it is Eisenmenger's physiology. So the patient had increased pulmonary blood flow and then he starts improving paradoxically. So it can be a sign of concern for the parents and for the clinician as well. So RVOT obstruction, which is acquired, gasolization or Eisenmenger physiology. So ये question answer हो गया, blood flow increase or reduce. Is it a low flow situation? It's a dominant RV or dominant LV situation, which may or may not be associated with pulmonary artery hypertension rarely, but by and large, physical examination, ECG and X-ray will be able to tell us as far as VSD PS physiology is concerned. So we will concentrate on non-restrictive VSD with severe PS, that is top physiology. So differential diagnosis, अगर आप देखें तो dominant RV, dominant LV. And I think many of you would be reading Dr. Kamal's book as well. So that's a very good book to read for the way you should handle the question and answers in the exam. So dominant RV with VSD PS physiology will be tetralogy, transposition, double outlet right ventricle, and VSD with PS. And dominant LV will be univentricular heart and tricuspid atresia. So it's very easy to remember dominant RV versus dominant LV. Pulmonary atresia and tract septum can be bracketed into dominant LV because basically the RV is small and underdeveloped. So pulmonary atresia and tract septum can also be clustered into dominant LV situations. टॉफ जैसे अभी आप लोगों ने देखा केस में भी डॉक्टर कमल डॉक्टर अजय ने पढ़ाया होगा, सेंट्रल साइनोसिस है, क्लबिंग है, नॉर्मल जेवीपी, नॉर्मल पल्स, नॉर्मल साइज हार्ट with barely audible, barely palpable grade 1 pulse. Dr. Kamal described a few situations where you can have tetralogy. Normal first heart sound, single second heart sound, ejection systolic murmur, which is inversely proportional to the intensity of cyanosis. Deeper the cyanosis, lesser will be the murmur, and you might get a aortic ejection click due to the dilated aorta, and no thrills. Genesis of the murmur also it was discussed during the case presentation. Dr. Kamal was telling it is although the VSD is large and non-restrictive, the RV and LV pressures are identical, so the murmur is generated from the RV outflow tract obstruction, and it is inversely proportional to the severity of PS. And he also mentioned कि यदि spells हो रहे होंगे तो murmur की intensity कम हो जाएगी. Pulmonary atresia में there may be no murmur, right? So these are the two situations where the murmur will become less and less prominent. Again, this also he discussed, and I think this is his favorite question, and I have heard it so many times during his classes. So these are the rare situations you should remember. Tetralogy with brisk pulse will be collaterals and AR. Continuous murmur will be, you might hear a murmur of the collaterals in pulmonary atresia situations. Systolodiastolic murmur, absent pulmonary valve, and a murmur of TR rare only in RV failure, restrictive VSD, associated hypertension, etc. So these are the four important variants of tetralogy and clinical examination you should remember. Why heart failure is rare in TOF, we all know that the VSD is large, non-restrictive, so the RV is effectively decompressed. He also discussed, again, these are very, very important exam questions. Heart failure and tetralogy, restrictive VSD, anemia, endocarditis, hypertension, AR, collaterals, and rarely pulmonary regurgitation, especially post-operative cases. So these are rare situations where heart failure will occur. So we'll quickly move on to clinical clues, ECG and X-ray. So onset of cyanosis, second heart sound if it is palpable, type of apex and prominent murmur. So this is we are discussing just VSD, PS or tetralogy physiology. ये डॉक्टर अजय महाजन ने भी शॉर्टली डिस्कस किया था. अगर साइनोसिस अर्ली है immediately or early after birth, it is suggestive of admixture lesion. Tetralogy में नहीं होगा. Tetralogy में cyanosis usually appears at 12 weeks or 6 months. So early after birth will be admixture lesion, tricuspid atresia, transposition, intact septum, pulmonary atresia, or any duct-dependent lesion. Greater the severity of cyanosis, more severe is the underlying lesion, obviously. So one is the appearance of cyanosis. Second is, this is the schematic of the clavicle and the sternum. So on the left side, if you are having a prominent palpable second heart sound in the second left intercostal space, VSD PS physiology, this is diagnostic of a L post aorta. So prominent palpable second heart sound. So if you move from onset of cyanosis to palpation, this is LTGA. Type of apex. So हमेशा अगर order में जाओगे भूलोगे नहीं चीजों को. Onset of cyanosis, palpable second sound, apex अगर prominent है, so usually suggestive of tricuspid atresia or univentricular heart of the LV type. Rarely double outlet right ventricle if the VSD is restrictive, but by and large, these are the two conditions, tricuspid atresia and univentricular heart. Audible murmur, murmur out of proportion to intensity of cyanosis. So either the murmur is coming from the VSD in a top situation, which will happen in either tricuspid atresia, single ventricle to the bulboventricular foramen, and rarely DORV with restrictive VSD. So these are the cases where you might have prominent murmur in a tetralogy situation, or the murmur is coming from AV valve regurgitation. So VSD PS physiology mein the only two situations you will have AV valve regurgitation is L transposition with Epstein malformation of the left AV valve or AVSD with PS. So these are the conditions you should remember. So reduced flow ho gaya, increased flow we will not discuss too much because TAPVC, truncus, ABSD, no PS. These are all in increased flow. So you will have cardiomegaly, S3, flow murmurs and rumble. But top physiology, ज़्यादातर exam में आता है, so you should be very, very well versed with top physiology. So these are the things, history, physical science हमने discuss कर लिया. Quickly we'll move on to the ECG. So classical tetralogy, I think Maulik discussed very well. So it's a right axis deviation. See this right axis? There is right ventricular hypertrophy and early transition. That is appearance of the S wave by V2. And you have a underfilled LV. So you have a RS complex in V5, V6. So this is classical tetralogy. So ये अगर आप देखो right axis more than 150 है. So this is in detransposition or DORB. दोनों में RVH होगा, लेकिन axis usually more rightward than tetralogy होगा. Now pointers in ECG. Remember these 5-6 things: late transition, RV strain, counterclockwise loop, left axis deviation in a VSD PS physiology. So we'll discuss them one by one quickly. तो अगर आप ये देखो late transition हो रहा है, you see V1, V2, and there is RV strain. So early transition can happen in both VSD PS and PS intact septum, but late transition will never happen in tetralogy. So यदि late transition हो रहा है, जैसे ये late transition हो रहा है, RV strain आ रहा है, so this is suggestive of severe PS intact septum. This cannot happen in your run-of-the-mill tetralogy. So late transition you should be aware, RV strain you should be aware. Loop, ये भी डॉक्टर कमल ने बताया था अभी. तो अगर आप देखो lead 2-3 AVF show you Q waves. This is a clockwise loop, more suggestive of tetralogy. Lead 1 and AVL show you Q waves. So this is counterclockwise loop. अगर dominant RV है, so counterclockwise loop with RVH, DORV and AVSD are the suggestive diagnosis. However, if you are getting a counterclockwise loop with LV forces, predominance. Now you are seeing right axis भी है और counter loop. The diagnosis is more suggestive of OR. Right. If you're getting a left axis deviation, no RV force, just see these situation है, left axis है, look at L1 and the RVH. Left axis AVS, right? अब दूसरा ECG आप तो इसी
Sir, I think because of network, we have lost your screen share. RX events?
Am I back again? I think I
Yes,
got
sir, you
logged
are
off.
back, but we can't see your screen.
You can't see my screen?
No, sir, no, sir. If you can
एक
share
बारी
again.
फिर
Now
से
we can. Yeah, you've started. Sir, now we can see. Yeah.
सॉरी चला गया एक मिनट सॉरी
Okay.
आ रहा है अभी
Yes, sir.
आ
Now we
गया
can see. Yes, yes, yes.
So as I was saying, left axis counterclockwise loop, absent RV forces, prominent LV forces will be tricuspid atresia. और ये वाला एग्जांपल अगर आप देखो लेफ्ट एक्सिस डिविएशन है, काउंटर क्लॉकवाइज लूप भी है लेकिन आरवीएच है. सो दिस इज एवीएसटी. सो दिस इज द वे यू
Okay. I think we lost Sir's network. So, RX Events, if you can talk to Sir and try to make him log in again. So, Majan sir, I think Dr. Kapoor sir has already shared a lot of insights. The ABCD, the criteria is known as Toscano-Barbosa criteria. Again, as sir was mentioning, a lot of favorite questions of mine. One of that favorite question is also Toscano-Barbosa criteria, which is the prolonged PR, anti-clockwise rotation, and bundle branch block. So, I think there are very specific. If you go through Perloff, a lot of specific diagnostic ECGs. And Perloff, there is a in the introductory chapter, the book writes that there is no disorder that cannot be categorized specifically purely based on ECG, X-ray, and clinical exam. So, Dr. Majan, sir, your comments on that. In the meantime, if the RX events can get Dr. Kapoor back on network.
The most important thing about top physiology is X-ray wise, you cannot differentiate, but the ECG is the most differentiating. On clinical examination and on ECG. We can come to around 90% correct diagnosis, and remaining 10% we can confirm with the echocardiography, and X-ray is slightly not that much helpful in diagnosing the top physiology. But for Eisenmenger, oh yes, X-ray is one of the important tool to come to the conclusion if it is a pre-track speed or post-track speed.
Right, sir. I'm trying to connect to Dr. Aditya Kapoor, sir. So, sir is logging back in 2 minutes. In the meanwhile, I'll take a Maulik, are you there? We can have some more Viva Voca with you so that the learning goes on. So we'll have some extempore Viva with you. Dr. Majan, sir, if you can ask some more questions along with me to Dr. Maulik on tetralogy. So let's go back to where we were. We were discussing about the so brain abscess versus superior sagittal sinus thrombosis. What is the incidence? Do you have any age cutoff? Who gets what more?
Sir, below 2 years, means 1.5 to 2 years, brain abscess is more, and after that, because of hyperviscosity, CVST is more common.
Very good. So this that 2 years is a cutoff for those who are along with us. That's the cutoff for which subgroup presents with what. Okay, can you tell me role of phlebotomy in these patients in tetralogy?
Sir, if patient is having hyperviscosity symptoms, then more than 65% of hematocrit, and patient is asymptomatic, then more than 70%.
Usually tetralogies don't get. Usually
Yes.
tetralogy patients are more likely to be anemic rather than
Yes, sir.
hyperviscosity. Most of the hyperviscosities come from Eason-Menge subgroup, or they come with adult tetralogy.
Yes,
All
sir.
right. So hyperviscosity, routine phlebotomy is class 3 indication as per the guidelines.
Yes.
Hydration is class 1 indication for most of these patients. Mazen sir.
How to treat a cyanotic spell?
Sir, the first is in patient putting patient in the knee chest position and calming the child. Then start with 100% oxygen and sedatives like morphine is the first choice. If not available, can we give midazolam or anything? Then with rapid saline bolus around 20 to 10 to 20 ml per kg. And then we can start with either propranolol can be given or vasopressor agents can be given, sir.
Right. So Kapoor sir is here. Sir, can you share your screen? So we
Yeah,
were
I'm so
just
sorry.
taking Maulik's Viva in the meantime. We continued his
Yeah, I'm
Viva.
so sorry यार वो कुछ यहाँ से connection टूट गया था. I'm
Now we
so
can
sorry.
see your slides, sir. Please go ahead. So over to Kapoor sir for pointers on ECG.
So I was talking about the absent RV forces, so stereotype complexes. So in the VSD-PS physiology, if you have stereotype complexes or monomorphic complexes from V1 to V6, so then you suspect obviously a univentricular physiology. And the last situation will be absent septal Q waves in V5, V6. Ventricular inversion hai, so no Q waves. Normally you get Q waves in V5, V6. So no Q waves in V5, V6. And you get a septal Q in V1, V2. So no Q waves in V5, V6 and septal Q waves in V1, V2. So that is suggestive of AV discordance or L transposition. So to summarize the ECG thing, पहले आप loop देखो, counterclockwise loop है कि नहीं है. काउंटर क्लॉकवाइज लूप में अगर आरवी डोमिनेंस है तो डीओआरवी या एवीएसडी, अगर एलवी डोमिनेंस है तो ट्राइकस्पिड एट्रीजिया. इफ यू आर हैविंग एब्सेंट आरवी फोर्सेस, it is usually suggestive of tricuspid atresia, pulmonary atresia with intact septum, or stereotype complexes in a univentricular heart. अगर टेट्रोलॉजी फिजियोलॉजी में लेफ्ट एक्सिस मिल रहा है तो ट्राइकस्पिड एट्रीजिया होगा जिसके अंदर एलवी फोर्सेस होंगे. अगर टेट्रोलॉजी फिजियोलॉजी में लेफ्ट एक्सिस मिल रहा है तो एवीएसडी होगा which will be RV dominant. Discordant axis and chamber enlargement. So discordant axis, chamber enlargement or stereotype complexes will happen in univentricular heart. By and large, we say that univentricular heart can come with any ECG, any axis, but discordant axis, chamber enlargement, monomorphic complexes, and absence of septal Q waves, that is, along with a Q positive in V1, V2, will suggest a L transposition. तो ये तो ECG का dissection हो गया. X-ray chest, I think Maulik very nicely described the tetralogy, physiology X-ray. So whenever you see the X-ray, as we have been taught, go semantically, go in order of sequence, cardiac size, chambers, pulmonary artery, arch, and the pulmonary blood flow. So tetralogy का X-ray सबको मालूम है, boot shaped heart, and you get pulmonary oligemia, you see the arch, whether it's a right-sided arch, you see the pulmonary bay, it's absent main pulmonary artery. So this is the classical tetralogy X-ray. Upturned apex, a pulmonary bay, and a oligemia. So tetralogy with prominent central pulmonary arteries. This is classical for, remember these X-rays, absent pulmonary valve. Rarely you may get a tetralogy with mildly prominent central pulmonary arteries, that is a valvular PS, when the obstruction is predominantly valvular. In fundibular PS होता है तो इसलिए PA is not dilated border forming classically in tetralogy, but if the obstruction is valvular, which happens in about 5 to 10% of cases, you might find a prominence over here. उतना prominent नहीं होगा जितना absent pulmonary valve में होगा, but it can be mildly prominent. Pulmonary atresia का जो X-ray होगा, again it's pathognomonic, dilated convex RA, dilated ascending aorta. Main pulmonary artery segment will be very, very concave because it's a pulmonary atresia. And you will find a lacy reticular lung pattern due to the collaterals. And rarely the collaterals may cause rib notching. So pulmonary atresia situation mein the X-ray will be classical. X-rays of tetralogy, physiology, we'll just discuss these 4-5 X-rays quickly. So DORV ka X-ray is by and large almost similar to tetralogy. If no significant PS in a DORV situation, it behaves like a VSD. Now see the second situation, a narrow vascular pedicle, egg on side appearance due to dilated RA and a prominent LV, more suggestive of a detransposition. So this is egg on side appearance, narrow vascular pedicle. Ascending aorta on the left, not right. PA is not border forming. Ascending aorta on the left. So this is L position. Remember L position we had discussed, you will get a palpable second impulse on the left intercostal space, left side intercostal space. Tricuspid atresia, again you will have a prominent RA shadow, no RV because RV chota hai. You will have a LV apex and a reduced pulmonary flow and a prominent aorta. So this is atresia. Which is the inverted outlet chamber. So you see this X-ray, low flow situation, a prominent cardiomegaly. So cardiomegaly usually tricuspid atresia में, ventricular tricuspid atresia में ये univentricular heart में मिलती है, and you find a bulge in the mid left upper cardiac border suggesting an inverted outlet chamber. Pulmonary atresia intact septum, again you will have a hugely dilated RA. The LV will be prominent. There will be no RV. And if the patient is very sick, develops severe TR, there will be huge aneurysmal RA and a big cardiomegaly. So this is almost like end stage. So briefly encapsulating the X-rays, tetralogy, DTGA, narrow vascular pedicle, egg on side, L transposition, prominent L post aorta, tricuspid atresia, univentricular heart with a bulge in the mid cardiac border and a prominent LV apex, and big RA, initially LV dilatation, but if the RV fails, you might find huge cardiomegaly, suggestive of pulmonary atresia and intact septum. So these are the 4-5 types of X-rays. So I'll just end with probably this slide. This is again a very commonly asked question. Pulmonary stenosis, that is RVOT obstruction with intact septum versus VSD-PS physiology. So सबसे पहले JVP, prominent A waves agar hain, so that suggests you PS intact septum. Usually JVP is normal in tetralogy. S2 is widely split in PS intact septum, single S2 in PS VSD. S4 is obviously present in PS intact septum. It is rare in tetralogy. Murmur हमने discuss किया, directly proportional to the severity of cyanosis versus in tetralogy it is inversely proportional. ECG we discussed. In PS intact septum, you will get late transition and you will get a RV strain, T-wave inversions. In tetralogy, there is an early transition. Tetralogy can never have late transition or RV strain. X-rays, PS intact septum, you will have a dilated PA and a cardiomegaly. Versus tetralogy, you will have a hypoplastic pulmonary artery or a pulmonary bay and usually obviously no cardiomegaly. On cardiac cath, RV systolic pressures can be suprasystemic in PS intact septum. It can never be suprasystemic in a routine tetralogy, apart from the Hoffman variant which Dr. Kamal discussed, where you can have a higher RV pressure. Because there is a large VSD, the RV pressure will always be systemic. So these are the ways you can differentiate the VSD-PS physiologies by ECG, by physical examination, by onset of cyanosis, by ECG, by X-ray, and very importantly, PS intact septum versus VSD-PS. So I'll stop here. Thank you. Thank you.
Thank you, Professor Dr. Aditya Kapoor sir. Beautiful presentation as always. मैं सोचता हूँ सर आप हर बार वही पुराना वाला लाओगे पर आप हर बार नया ही presentation लेके आते हो. And there's always a learning experience.
We are testing ourselves. You are such a phenomenal teacher, so we have to update.
It's always a pleasure listening to you as a faculty also. We are still students with you. So thank you very much. Beautiful presentation. Dr. Majan, sir?
It is one of the most important thing is that we have to see this presentation once and twice prior to going to take exam because it is very good presentation. Chris.
Thank you.
So thank you very much, sir.
आप दोनों भी करेंगे तो अच्छा रहता है.
So thank you very much, sir. Dr. Aditya Kapoor, sir, Dr. Ajay Mahajan, sir, and Dr. Maulik, thank you for presenting
you,
the
sir.
case today. That brings us to the end of the session for today, but we'll be back with you on 7th of November, again 8 p.m., where Dr. Prarthi is going to present a case of constriction versus restriction. And the faculty would be Dr. Professor Sohan Kumar Sharma from SMS Medical College, Jaipur. He'll be taking us through the nitty-gritties of comparing constriction versus restriction cases, which Dr. Prarthi will do as a case presentation. He'll be taking us through clinical cath and echo features of RCMP versus CCP, which is again a very important question, both in Viva as well as long questions very often asked in all the theory and all the entrance examination for that matter. So with that, Dr. Mahajan, sir, over to you, and then probably we can end the session.
Thank you everyone for this particular wonderful session, and we'll meet on 7th of November. So happy Diwali to everyone in advance. Enjoy, take care.
Thank you.
Thank you. Good night, sir. Thank you. Bye-bye.
Bye-bye.